Hi, caregivers. We are so excited this morning at the Wake Forest Dementia Caregiver class to have Dr. Andrea Bozoki, who is the Chief of Cognitive Behavioral Division at UNC Chapel Hill's Cognitive and Memory Disorders Clinic. And she's also co-lead of the Outreach, Recruitment and Engagement Core of the joint Duke-UNC Alzheimer's Disease Research Center. Dr. Bozoki is a cognitive behavioral neurologist. She arrived at UNC in September of 2020. By the way, she was handpicked by Dr. Daniel Coffer, who was the founder of that clinic. She had a long career at Michigan State University before coming to UNC Chapel Hill, and she specializes in clinical care of those with cognitive decline due to some form of neurodegeneration. She also engages in clinical research for both Lewy body disease and frontotemporal dementia. And in addition to that, last year, she's been working collaboratively with a group of physicians and administrators at Chapel Hill to create a program for those with early stage Alzheimer's disease to receive the newly FDA-approved anti-amyloid therapeutics. So you can see she's very active. And we are very excited to have her today. And she's going to be speaking to us today about what's the latest that's going on in terms of treatments and research and anything that's new, and kind of updating all of us on what's going on in the world of dementia. And so I'm going to be turning it over to you, Dr. Bozoki, if you want to turn your microphone back on.
Certainly. Pat, thank you so much for that kind introduction. And the hope and goal of this is to engender thought and questions, but I will try to present the information first and then leave as much time as we need and as Pat is willing to give me to answer questions both about anything I've presented and about whatever other issues might be top of mind for you. Okay. And there we go. Hopefully you all are seeing my first slide, and I'm going to take a moment to minimize the other kinds of things on my screen so that I can see my own slides here. There. If you do have a question, because I won't be able to see the chat very easily during this, you would need to unmute and actually say something, or I won't know. All right. Pat and I agreed that the focus of today would be on sort of new-ish, at least, information from research into both Alzheimer's and Lewy body disease. And you'll see throughout, I've tried to highlight where information is different between the two disorders. In some ways, though, what is good for the brain is good for the brain, and you'll see that some things apply across the neurodegeneration spectrum. So, oh gosh, there we go. Perfect. Just a few brief reminders for anyone who's unclear. This is probably the single most frequent question I get asked. Doctor, what's the difference between dementia and Alzheimer's? So dementia is cognitive decline that has already impaired one's daily activities or resulted in a loss of functioning. And of course, we've excluded that it's from other things like medical illness. And importantly, from the standpoint of, dementia being different from something like mental retardation, this is a decline compared to one's pre-illness baseline. Importantly also, dementia is a description. It is not a diagnosis. Okay, so it's a syndrome, and you can see underneath various types of or specific causes of dementia. Similarly, there is an entity called mild cognitive impairment. Mild cognitive impairment is also a description and not a diagnosis. It refers to a stage of cognitive decline that is less severe than dementia in that it has not yet impaired one's daily activities. And it also can be due to one of these specific neurodegenerative entities, but just like dementia, there are non-neurodegenerative causes for each of these things, both dementia and MCI. And that's a really important piece of information for doctors to keep in mind so they don't just jump to conclusions. Okay, few more definitions. Alzheimer's is, right, so now you know, a specific disease that is neurodegenerative and causes loss of neurons over time. It is a neurodegeneration that is associated with very high levels of two types of neuronal protein, one called beta amyloid and one called tau. As I've alluded, it can present initially as a transitional state of MCI. And when we know that that MCI is due to beta amyloid and tau, we call it MCI due to AD. Importantly, with Alzheimer's disease, we also know that there is a long silent period. Okay, so somewhere between 15 and 20 years before the very beginning of the MCI stage, people start to silently accumulate beta amyloid. And some number of years thereafter, they start to experience, again, the silent spread of abnormally hyperphosphorylated tau tangles. These are proteins that sort of glue themselves to each other to create accumulations. And only after some years of the tau accumulation and spread will you start to have the first clinical symptoms. So that brings up the corollary that not everyone with Alzheimer's disease pathology has dementia, right? So in contrast, Lewy body disease, also a specific neurodegenerative disease that can cause dementia, and it too is progressive over time. It too is involved with an abnormally high level of a neuronal protein. This one is called alpha-synuclein. And it too frequently has a transitional state of mild cognitive impairment. And, you know, when the we say MCI due to LBD, when alpha-synuclein is the biomarker that is found in association with that mild cognitive impairment. Differently from Alzheimer's disease, although alpha-synuclein can also start accumulating in various places up to 20 years before someone gets clinical symptoms of dementia, that alpha-synuclein accumulation in various places is not usually clinically silent. And you are all familiar with a number of non-cognitive features of Lewy body disease, and I can say alpha-synuclein is also the culprit in Parkinson's disease. And if you have any familiarity with PD, you know that PD also has these premotor symptoms, some of which are shared with Lewy body disease, especially a loss of sense of smell, the development of constipation, or REM sleep behavior disorders. And so these are caused, we think, by abnormal overaccumulation of alpha-synuclein in different places, both in the brain and in the body. Body being the gut. And the gut has its own enteric nervous system. And it turns out that alpha-synuclein can be manifested in those gut neurons, so to speak, nerve cells. We don't call them neurons in the periphery. We think that for some people, there is a spread. You can look at the slide picture A, spread from the gut up to the brainstem and eventually over to the olfactory cortex. That's what those 3 red dots represent. That is the traditional means of progression in Parkinson's disease. B, C, and D reflect different patterns of onset of the alpha-synuclein that are more closely tied to Lewy body disease. And you can see that alpha-synuclein can start in one place and spread either up or down. It can even perhaps, this is less proven, start in multiple different places at once and spread from each of them. So this is new knowledge. This is new science in the last 4 or 5 years, just so you know. All right. Having done my definitions and explanations, I want to highlight in the next few slides some recent research advances in an area that you don't always think of when you think about dementia research, but I think is particularly important for the population as a whole. And that is interventions that are not pharmacologic and that at the population level can reduce the chances of a particular individual developing dementia or developing it sooner rather than later. So the first of these is an evolving understanding of what elements of our diet are related to brain health, and conversely, what elements are related to brain illness. So it is pretty clear that a diet that emphasizes consumption of legumes, whole grains, fruits, vegetables, and fats from plants rather than animals turns out to be far more healthful for the brain. It likely reflects the kind of diet that our ancestors ate for the most part, especially when they weren't quite as agile in catching and killing animal prey, and certainly reflected the majority of what we used to eat back in the day. A newer understanding that has come out in the last, say, 5 or 6 years is a parallel understanding that certain types of food products that are available to us in abundance and it can represent the bulk of what we eat, even if you're a vegetarian, even if you're a vegan, okay, are independently of kind of the above somewhat, also associated with poor brain health. And this is a class of foods that are referred to as ultra-processed. So the definition is there to the left, ingredients that are never or rarely used in kitchens, classes of additives whose function is only to make that final product palatable, more appealing, and I would add, or more shelf stable, right? When you see food that's in bags and boxes that can last on your shelf for 6 to 12 months without going stale, there's a reason for that. And it turns out that the more of these types of foods you have in your diet as a whole, the more likely you are to develop a range of diseases, not just neurodegeneration, but also other bad things like cancer and heart disease. Okay. The next important research finding that I'd like to present is a study called ACHIEVE, Aging and Cognitive Health Evaluation in Elders, which had multiple aims, but the one that I find to be and was acknowledged to be sort of the most important finding in the study was that actually intervening in individuals who had mild to moderate hearing loss, prescribing and encouraging the use of hearing aids slowed down loss of thinking and memory abilities by half. over 3 years. So none of these at the start of this study, no one in the study of over 370 individuals, had any form of cognitive decline. They just had hearing issues, and half of them were also at risk of, were felt to be at high risk for cardiovascular problems. And in the group that was at higher risk, there was a very substantial impact of providing hearing aids. There's a number of reasons we think for that. You can see over to the left, hearing loss increases cognitive load. You have to work harder to make sense of what people are saying. That leaves less attention for other aspects of language processing, and the brains of people with hearing loss atrophy more quickly than those of people with normal hearing. Literally, the parts of the brain that process language, when they don't get clear information, start to involute and become dysfunctional. So the takeaway point of this is get your hearing tested every few years, and if it has reached the threshold of at least 20 to 25 decibels of loss, please consider getting and wearing hearing aids, because it does no good to you in the box. Okay. A third big non-pharmacologic research finding that I feel has not gotten as much adoption by primary care as it should, considering that this study came out, the results of this are now 5 years old, is the results of a study called the Sprint Mind study. So the Sprint study itself was a very large study of something like 8,000 people that looked primarily at cardiovascular function, with an end result of whether somebody got a heart attack or not, if one of two conditions occurred, if their blood pressure was controlled to a systolic of 140, or if it was controlled to a systolic of 120. And that main study of over 8,000 people was stopped early, 2 years early, by the Data Safety Monitoring Board. It was supposed to go for 5 years. It only went for 3 because the Safety Monitoring Board said it is unethical to continue to the end of the study because there was such a drastic and dramatic drop in the number of cardiovascular endpoints, meaning heart attacks, in the 120 group. Okay, so bear that in mind. So there was a sub-study that had about 15 to 1,800 people in it, called Sprint Mind, that looked at an additional endpoint of cognitive decline. So everybody who started Sprint Mind was cognitively normal. And they looked to see in that smaller group that had cognitive testing along with the heart testing, how many of them in each of the two groups developed either MCI or dementia. What they found over 3 years is that the intensive blood pressure control significantly reduced the risk of MCI and also the combined endpoint of MCI or dementia. Because it only went for 3 years, and it usually takes 4 to 5 to go from normal to demented, it did not show an improvement in the rate of developing dementia alone. Everyone is pretty convinced that had they been allowed to go the full 5 years, that would have become evident as well, because, right, most people go on from MCI to develop full-blown dementia. So the bottom line, do not be satisfied if your blood pressure is in the 130s for the systolic. Still not good. Okay. There has been a considerable amount of research on the behavioral management of later stage dementia in the last decade. I am not going to steal the thunder of my colleague in September by talking a lot about drugs, but I will present to you the results of several different studies. Well, I will summarize the results of several different studies which uniformly show that the single most important intervention that you can make for irritability, agitation, or sundowning is caregiver training. Okay, hands down, caregiver training works better than medications in a wider variety of environments. Having said that, the patient's environment is the second most impactful change that can be made, whereas drugs are only number 3. Okay. Below my sort of headline information, you'll see some resources. Okay, so caregiver training, in addition to the invaluable training that you're getting by being part of this support group, which has a class with it, right? There are several great YouTube-based resources that are free. One is Dementia Care Blazers. The other is The Positive Approach to Care, led respectively by Natalie Edmonds, a PhD psychologist who specializes in gerontology, Teepa Snow, who I believe started out as an occupational therapist and has evolved to be one of our nation's gurus for care and management of later stage dementia patients. They have whole libraries of videos that you can review, categorize neatly into different topics and subtopics. Please take a look. Okay, so there is also a paid website that offers an online training course, which is more systematic, right, than the kind of individual videos that you can look at on the Care Blazers or Positive Approach sites. This training course also comes with a manual. It is paid, it's not super expensive. It's in the vicinity of, I think, $200, $250. I'm sorry, I haven't looked recently at the price. And it is led by Helen Kales, who is a geriatric psychiatrist. Some specific information that is, again, kind of consolidated from a variety of publications in the last 5 or 6 years on these topics. When you're targeting environment, okay, look around, consider all of the following, sources of loud noise, overactivity, especially intellectual, cognitive type overactivity that is being expected or asked of a particular patient. Look at physical clutter. Okay, so the amount of visual complication in one's environment can in and of itself be stimulation that a brain with dementia can't really function well with. Even if that person's home has historically and for the longest time had, moderate to severe clutter, decluttering it now, even though it will be, less familiar, can make them function better and stay calmer. Crowds are bad. Usually being surrounded by unfamiliar people is a problem typically. And that includes bringing less familiar people into one's own home. That brings up an issue, which is if you're thinking that in the future you might need to have substitute caregivers because you will need respite from time to time, for the love of God, bring them in sooner rather than later so that they can become familiar. So need to simplify, declutter, keep a stable routine. Please keep everything in the same place all the time. For the specific problem of sundowning, sometimes a brief-ish after lunch nap, don't allow it to go for more than an hour, preferably not even for an hour, can be a way of resetting the brain. If somebody is sundowning and very agitated, taking a walk or a short drive in that agitation period where they're kind of wanting to leave and not recognizing that their home is their home, leaving and then coming back to the house seems to be an approach that also helps often with a reset. A nod to Lynn's comment about deprescribing. Before you add new medications to help with irritability, talk to your doctor about de-prescribing trials, okay? And be sure to review any non-prescription medicines that the patient is taking, in addition to the ones that have been actually prescribed, because sometimes it's that Benadryl or similar that is the real culprit, okay? And my last comment is the first line treatment for irritability and sundowning is usually not an antipsychotic as the first line, but an antidepressant. It doesn't always work. It doesn't even that often work, but when it does work, it's infinitely preferable as it has fewer side effects, less long-term complications than the antipsychotics. So I am now going to move to some more recent findings and rollouts. New diagnostics, and I subtitled this, "The Age of Biological Diagnosis is Here." Any of you who've been to an old school doctor or went, with a parent or an older family member 10, 15 years ago know that diagnosis for neurodegenerative diseases was entirely clinically based, right? And the explanation was that the definition of these entities was based on pathology at autopsy, and there was no way to look inside the brain tissue prior to death in ways that would be definitive. So that has changed. I am going to skip over an entire 15 years worth of research that allowed us to start diagnosing Alzheimer's disease using tools that include PET scanning and spinal fluid testing, and jump straight to the newest evolution in Alzheimer's diagnosis, which is that blood-based testing is now a reality. The first few blood-based tests for beta amyloid and or phospho-tau are now commercially available, orderable by physicians. And the one here called Precivity 82, which is just sort of the brand name of the test that is put out by a company called C2N Diagnostics, is the one that we have started pilot testing at UNC. Literally, the kits are in our lab. We're just clarifying what paperwork has to be submitted with the kit, or in what time frame for the lab to process the samples, and we should be up and running. For a while, I will be doing this blood testing in parallel with our usual spinal fluid testing, because there is not a lot of data telling us what the relationship is between spinal fluid result and serum result. But eventually the majority of people, and certainly people at outlying hospitals and medical centers, not at the flagship here in Chapel Hill, will almost certainly get a blood test to begin with, and only if it's equivocal will they move on to a second line test like the cerebrospinal fluid or a PET scan. Please note that currently this test is not covered by insurance. The company does have an aggressive financial support process that means that basically nobody pays more than $400 out of pocket. If you're wondering what AUCROC means on this slide, area under the curve, receiver operating characteristic, is a fancy word for approximately what percent of individuals who are tested with this you're able to sort of conclusively say, well, that the test is positive or negative. Okay. In parallel with testing for Alzheimer's disease, we now also have reliable testing for Lewy body disease. This is a huge advance and rather a newer phenomenon in that there was no previous, PET imaging or cerebrospinal fluid testing that was great. We did have a type of SPECT imaging called a DAT scan that was able to detect dopamine transporter abnormalities in patients. The problem is that about 25% of DLB folks didn't have an abnormal DAT. So it wasn't great as a tool for DLB. This new skin biopsy looks directly for alpha-synuclein. It looks for it in skin nerve cells, which it turns out is as much of a thing in Parkinson's and Lewy body disease as the same alpha-synuclein in the gut. And in fact, it is far more commonly positive in Lewy body disease early on than gut alpha-synuclein is. So you can see a little picture off to the right of sort of what the staining looks like, and the squiggly down, line where you see sort of orange and yellow. That is an alpha-synuclein fibril. And it is not that you see it very clearly, but it's inside of a neuron, a nerve cell, sorry, peripherally. And that kind of phosphorylated alpha-synuclein is only detected in people who have a synucleinopathy, very, very sensitive, and also quite specific. This is really a home run in terms of diagnostic accuracy. The skin punch biopsy procedure is done on 3 different sites. Teeny tiny specimens, size of a head of a racer, are taken. Kits can be ordered from the company CND Life Sciences, which sounds unfortunately a little too much like C2N, but they're not the same. And they will provide training on how to get the samples. So if you're at an outlying location and your doctor is willing, you don't need to be sent to UNC to get this done. And unlike the blood test at the moment, this is covered by most insurances. I will briefly mention that there is also, in the last year and a half, a cerebrospinal fluid test for alpha-synuclein. It's called the SynTap test, and it's from a company called Amprion. The picture to the bottom explains how this testing is accomplished. There's only a few little molecules, usually of alpha-synuclein, in a sample of spinal fluid, and the way they figure out whether it's abnormal or not is by throwing in a seed of man-made misfolded alpha-synuclein, the kind that's abnormal, and then they shake the sample, and apparently the misfolded alpha-synuclein serves as a template to make the abnormal if there is abnormal alpha-synuclein in the spinal fluid, it will glue to it, okay? And they do this repeatedly over multiple sessions of the test tube, and adding more of this recombinant alpha-synuclein seed in order to get enough of activity to say reliably with a machine, yes or no, is there this kind of abnormal alpha-synuclein in the sample or not? Both because it's not covered by insurance and it's more expensive, and because of its lower sensitivity and specificity, we're not doing this test. Sort of related, but not entirely, to new kinds of testing is a different type of research that I wanted to highlight, which is something that I was actually involved with creating in the last couple of years, and that is a Lewy management toolkit. Okay, so this was a sort of an arduous process of taking literally hundreds of research studies in regarding various aspects of the care and management of patients with Lewy body disease, and sort of pulling them together as a series of recommendations and best practices to be provided to clinicians. I don't expect that you are able to, nor would I need you to look at or read all of the tiny print. But what the takeaway is that we started with a pre-existing older set of recommendations from Newcastle University in the UK. We did, an exhaustive lit search from the last 5 years since they had published, made a whole slew of modifications, and now, as of 2 months ago, 3 months ago, these are now available and are being sent out to practitioners who ask for them through the LBDA website. And they cover, as you can see, all of the different domains that Lewy body dementia affects: cognitive, neuropsychiatric, sleep, autonomic, and motor symptoms. The last thing that I am going to let you know about that is on the horizon in terms of diagnostics is that the framework, because of the spinal fluid and skin testing, and because of the previously available DAT scan and another tool called MIBG cardiac scintigraphy, which in the US is very underutilized. But because these biomarkers are now available, there are several different groups, both in the US and in Europe, that are working to both unify Parkinson's and Lewy body disease under one roof, since they really do represent differing distributions of alpha-synuclein, but are largely caused by the same etiology, the same, underlying problem. And there's also, in parallel, work being done to finally create a clinical staging system, which is not yet, still not available. But we're moving from a pathologic diagnosis of Lewy body disease, at autopsy by looking in the brain, to the way it's being done now for Alzheimer's disease by looking at biomarker spread and extent and the impact of the various clinical symptoms in combination. So just if you hear in the future, there's the NSDISS scheme versus the Synergy scheme, and there are likely to be more of these before we settle on a final kind of staging system. Okay. I don't know if any of you have seen a slide like this. This research is by Dr. Jeffrey Cummings. Every year now for the last 5 or 6, he has put together an overall survey of all the Alzheimer's trials that are being conducted during the year. And he has sort of categorized and subcategorized them, both based on the phase of the trial and on the function or purpose of the drug. And so this year's bullseye picture for Alzheimer's drug development shows 164 trials assessing 127 different drug pharmacologic interventions. And of those, 48 are in phase 3, testing 32 drugs. So phase 3 is the final phase that needs to happen before a company submits for FDA approval. 48 in phase 3 is the highest that we've ever had. Okay, so That's very encouraging. What is maybe a little less encouraging, right, is that the total development time for a new therapy to progress from animals to FDA review is taking about 13 years. And that, in large part, is because these drugs need to be tested for 12 to 18 months in a single individual for the ones that are disease modifiers to know whether they modify the disease or not. Pat, what were you going to say?
Oh, I didn't, hold on. I don't think I was going to say anything. I'm just marveling. I'm marveling at this chart and excited about 48 trials.
Right. 32 drugs. So in the last couple of years, a different researcher has started doing the same thing for Lewy body disease, okay? And when you look at this and you say, oh gosh, this is so much smaller than the one for Alzheimer's disease, I beg you to remember that 5 years ago, okay, there was literally almost zero. Okay, Lewy body disease was barely, recognized as being a separate entity from Parkinson's. The Parkinson's research world looks quite similar to the Alzheimer's research world, but DLB is its own condition, had basically just about nothing. So the fact that there are now 7 phase 3 clinical trials, okay, is a huge advance. Unfortunately, or maybe fortunately, if you're at the stage when prevention or slowing really is not an option anymore, all of the phase 3 studies are for symptomatic treatments, right? Things that are essentially cognitive enhancers, or therefore to try to help improve the neuropsychiatric, behavioral, or motor symptoms. There are in phase 2 clinical trials, 8 that are disease modifying therapies, being tested on early stage DLB patients without comorbid Alzheimer's disease, to see if in that early stage it will serve to slow down something. So unfortunately, as you know, no currently approved therapeutics that are specifically for DLB other than rivastigmine, which is Exelon. But hopefully there will be some on the horizon soon. Okay. I have to put in a plug as a research scientist and a clinical trials specialist. I have to put in a plug and almost a beg to please, please, please consider participating in clinical trials, even ones that don't look like they're going to help you directly benefit. The only way any of the stuff that I just finished presenting to you will make it, or did make it, is through people selflessly offering up their time and energy in order to participate. The easiest way to do this nowadays is through a service called Trial Match that's offered through the Alzheimer's Association. It's easier and more user-friendly than the master site it pulls from, which is clinicaltrials.gov. And you can see in the inset window that even though this is the Alzheimer's Association, they will pull for multiple different types of dementia. So not just Alzheimer's, but also Lewy body disease trials can be found this way. And by the way, MCI studies, both due to Alzheimer's or more generally MCI studies, are also available. Right, and the website is right there, and that's the title, trialmatch.alz.org. Okay. A moment possibly of humor, I don't know, but this is a short, not complete list of the many, many things that have been claimed to help dementia, but either definitely don't or probably don't, including my favorite, which is ozone therapy, applied in oh so many different ways. Please, the bottom line is, if it hasn't been tested in humans using a placebo control in a format in which neither patients nor evaluators know who's getting what, and using an objective outcome measure that is decided in advance, right? And not you do 20 things and then look at which one did the best post hoc and declare that that one is the one that shows an improvement. Okay, so if you don't follow these rules of good research practice, then that whatever that study was is not worth the time and effort it took to do it. Okay, there's not medically, scientifically sound evidence that it works, no matter how many testimonials that thing has about the miracle improvement that so-and-so had as soon as they started X. So I am now sort of transitioning to talking about a thing that Pat specifically requested that I discuss, which is the now not research, but clinically available anti-amyloid antibody therapy, which is only for Alzheimer's disease, because only Alzheimer's disease, as it is defined currently, has the beta amyloid that these drugs target. Okay, so beta amyloid therapies are man-made antibodies attaching to a portion of that beta amyloid molecule once it's been ejected from neurons. And it allows that beta amyloid fibril or oligomer or plaque to be removed by the brain's own immune cells, which are called microglia. And underneath, it shows the 3 approved drugs and what form of beta amyloid they primarily target. You can see that lecanemab targets pre-plaque stage beta amyloid when it's still kind of floating around in solution, whereas donanemab specifically targets the completed plaques and sucks them out of the brain as, you know, big globs of abnormal protein. That, I think, has a lot to do with, as we have learned, the slightly higher risk of side effects from donanemab because it's taking bigger pieces of protein out of the brain. But all 3 do have side effects that I'll highlight. I thought that I could not do a better job of explaining in a short time how the MABs, these anti-amyloid therapies, work than this video from the New England Journal of Medicine. It's a minute and a half. So hopefully that's a clear and concise summary. I thought you might want a little bit more explanation about the two major types of side effects. So the first thing that he alluded to are what is commonly known as ARIA, a really pretty word for amyloid-related imaging abnormalities. The reason it's called that, rather than something like brain swelling, is partly semantics, but also to highlight the fact that most people with the kind of change caused by one of these MABs don't get symptoms. Okay, so they are purely imaging. You see it on an MRI scan, but it's not something you can feel or tell that you have. The ARIA-E for edema is a temporary swelling in an area of the brain that resolves over time. ARIA-H is microhemorrhage, okay, small spots of bleeding on the surface of the brain. And occasionally larger areas of bleeding can also occur. And when people do get symptoms, and the severity of the symptoms, of course, can also vary. It ranges from headache, confusion, dizziness, as you can see, nausea, sort of milder things, but certainly you can have more serious complications, seizures, or a brain bleed large enough that it causes stroke symptoms. Okay. The other type of problem is called an infusion-related reaction. This is actually a lot more common than ARIA that causes symptoms. In my hands, about 1 in 5 of the patients we've treated so far at UNC gets this, usually in the hours after the infusion, somewhere between 1 and 6 hours later, a flu-like symptom of body aches, chills, fever, lightheadedness, pounding heart, or trouble with shortness of breath. This is not an allergy. It is a hypersensitivity reaction, right? So this is something that happens same day, as opposed to ARIA, which happens, days to weeks after an infusion. And it can be prevented with the use of a combination of Tylenol, Benadryl, and prednisone. So it's really not a reason to not get lecanemab, whereas getting ARIA, depending on how severe it is, is sometimes a reason to stop. Okay. So there are two areas of risk that I want to highlight for these monoclonal anti-amyloid antibodies as a group. This isn't about donanemab or lecanemab or aducanumab, which is now off the market. As a group, people who are apolipoprotein E homozygotes for the E4 variant, okay, are at much higher risk of getting ARIA than those who are not. So apolipoprotein E is a protein that plays a role somehow in the brain for neuronal protection versus inflammation. The E2 variety is protective. The E4 variety makes you more predisposed to developing Alzheimer's disease and at a younger age. And everybody has 2 copies of every gene, not just ApoE gene, right? And so the people who end up with 2 copies of E4 are not only at highest risk of getting Alzheimer's, not only at highest risk of getting it early, young meaning, right? But they're also 4 times as likely to get ARIA as those who don't have a copy of E4. And in addition, it seemed in the studies that the subgroup of folks who had 2 E4s also didn't show any disease slowing. So at UNC, we do not infuse anyone who has 2 copies of E4. The other risk for receiving lecanemab is evidence that you're already prone to bleeding or swelling in the brain before you even start. So everybody gets a high-resolution, good quality brain scan that looks for pre-existing microbleeds or swelling. So the swelling is usually not there, but pre-existing microbleeds are not an unusual finding. And in the clinical trials that tested these drugs, people who had more than 4 of these little microbleeds, I mean, literally, they're the size of a head of a pin, most of them, were excluded from the clinical trial. They were considered to be too high risk to test the drug on. And when the people who had 1 to 4 microbleeds were analyzed after the study was completed, those who had more than 1, so they had 2, 3, or 4, actually did show greater risk of having ARIA when they were exposed to the drug compared to those who had 0 or 1. We are following the original protocol. At UNC, we will not infuse you if you have more than 4 microhemorrhages or any signs of larger, prior hemorrhage in the brain. Okay. I also want to highlight something that has given me a lot of lost sleep and has made me work a whole lot harder than I have in the past. Okay, and that is when these drugs work the best. So in the newly approved donanemab, okay, that's Kisunla or something, whatever the hell they've called it, that's the one that just got approved. In that study, they actually divided their sample into 2 groups. Those that had, along with beta amyloid in the brain, only a little tau spread, and those that had a lot of tau spread. Keeping in mind that every single person in that study was only very mildly impaired, right? They had an MMSE, all of them, more of equal to or greater than 22. So it turns out that, even at the stage of very mild impairment cognitively, there's already people who have a lot of tau spread. Very clearly, those with less tau did a lot better, okay? They had a substantially greater plateauing in their response than the people that had a higher amount of tau. In the lecanemab study, so now changing drugs, they didn't do this, but they obviously also did some tau imaging in some of the people that they infused. And when they reviewed who did better and who did worse at the single subject level, okay, they found that the group that had MCI did better than the group with mild AD, and the group that had less tau got the most benefit by far. So they really echoed the findings of the donanemab people, but just retrospectively. In both studies, people with a lot of tau did not benefit at all compared to placebo. Now, we can quarrel or quibble or discuss what is a lot of tau. We don't have that magic number right now, but the conclusion that I took from this is that time is brain, like in a stroke. If you have Alzheimer's disease, the sooner you're treated, the better chance you have of slowing it down. The corollary of this is there's no role for an anti-amyloid therapy in later stages of Alzheimer's. It's futile, and I, would not advise treating people who are already at the moderate stage or beyond. We're almost done. So the logistics of getting an anti-amyloid therapy are not trivial because these drugs are given intravenously, okay? Monoclonal antibodies can't be turned into a pill. That means, right, you have to show up at an infusion center, they get a needle in a vein and lie there while it infuses. And they have to be repeated. So lecanemab currently is a frequency of every 2 weeks. Donanemab is once a month. And right now, there are very few places around the state and indeed around the country, but in North Carolina, there are only a handful of places that are able to give these infusions right now. And a big part of my life and time have been consumed in the last 6 months by helping UNC figure out when and how to safely roll this out to other facilities in other ways to allow a greater percentage of individuals who meet criteria to get infused sooner. My very last slide, because there are a lot of people here who have loved ones with Lewy body disease and not Alzheimer's disease. And I have a lot of interest in helping those with DLB. And we know from many studies that often Lewy body pathology, meaning alpha-synuclein, and Alzheimer's pathology in the form of beta amyloid go hand in hand. There are a lot of people, in fact, almost 40% in one autopsy study of patients with DLB also have Alzheimer's pathology. So why not just give it to them? And maybe slow down their disease progression. And unfortunately, these days, science and medical care have been de-risked, okay? And because partly there have been, too many lawsuits over too many negative or adverse outcomes from things that were not well enough studied, too many patients have been harmed by treatments that were not well studied in that patient population. I know there's a third thing, but because of lots of factors, okay, we don't just give drugs off label anymore, especially one as complex and high risk as this one. So what I'm showing you here, not that you need to read the whole thing, is just a project that I am hoping to get involved in, which is an invitation to create and conduct a clinical trial of people who have DLB or MCI due to Lewy body pathology with comorbid beta amyloid pathology based on spinal fluid or serum or what have you testing, right? And we'll be designing and writing up this proposal, which has a due date of January 24th, 2025. And you can see the earliest start date for such a trial will be realistically January of 2026, and almost certainly will take 3 years to complete. So alas, we're not looking at use of anti-amyloid therapy in folks who have both DLB and AD pathology anytime soon. Okay, and with that, I am wrapping up. I'm going to stop my screen share. Okay. And I will